Now let us talk about lactoferrin, a very important substance. Where do we find it? It is an iron binding protein. It has got an antimicrobial property. Why? It will hold the iron so tightly that iron is not available for bacteria. It's like snatching the iron away from bacteria, that it has got a antimicrobial property, because some bacteria require iron to grow. So lactoferrin does not transfer iron, rather it will snatch the iron from the microbes and prevent their growth from happening. So that is how it is antimicrobial. So it is found in the secondary granules of the neutrophil and also in exocrine secretions of the body. Wherever microbes will be coming, their lactoferrin will be sitting and it will be snatching away the iron from them. So this is how lactoferrin has anti-inflammatory, bacterial killing property, antiviral property, fungicidal property. It is basically located in the secondary granules of the neutrophil is what need to be remembered. Increased capillary permeability. What is the main reason? Histamine causes vasodilation and edema. Anaphylatoxin and serotonin, all of them basically will lead to increased capillary permeability at the time of inflammation. Now let us comment about cytokines. What are cytokines, doctor? They are the peptide mediators of the intracellular intracellular messengers they are, and they exhibit lot of biological properties important for the inflammation, and that is the general introduction about cytokines. Now out of all these which are involved in the inflammation, which are the mediators of inflammation, tuber necrosis factor, interleukin 1, prostaglandins, they are all mediators of inflammation. Then what is this myeloperoxidase is my question to all of you. Myeloperoxidase is not an inflammatory mediator, but it is very important for the bactericidal property of our neutrophils. Why? Whenever a microbe is engulfed by a phagocyte, how does it kill? Two mechanisms. Oxygen dependent killing of it, oxygen independent mechanism of killing of a microbe. Myeloperoxidase comes in the oxygen dependent mechanisms of killing of the microbes by our macrophages. So what does it do? It basically combines the chloride and convert that into hypochlorous acid, HOCl, and that free radical will then kill the microbe. So myeloperoxidase is an enzyme involved in the oxygen dependent microbial killing mechanisms is what you need to fundamentally understand. So then what are called as mediators of inflammation? Fundamental question. Some are plasma derived, some are cell derived. I leave a small list for you which does not require a big explanation. At least you should be sure what is the source of it, what is the effect of it on vascular leakage, chemotaxis, etc., etc. It is all very, very essential. Now let us go to the next question, but before that be very sure, doctor, vasodilation is mediated by prostaglandins and nitric oxide and histamine. Vascular permeability is mediated by bradykinin, C3a, C5a, vasoactive amines and leukotriene C4, D4, F4, and also platelet activating factor and substance P. Then chemotaxis is mediated by the leukotriene B4, LTB4 is chemotaxis, LTC4, D4, E4 is basically for vascular permeability. You must be very sure differences between LTB4 and C4. Then fever is mediated by interleukin 1 and tuber necrosis factor, and pain is mediated by bradykinin, another favorite question of examiner, and tissue damage is mediated by the neutrophils, macrophages, etc., etc. Now out of all this, prostaglandins, kallikrein, C3a, they are all the mediators of the acute inflammation is what you need to fundamentally remember. In acute inflammation, contraction of the endothelial cell cytoskeleton is a part of which phase of the inflammation. When the inflammation begins, there is an early transient rise of permeability and there is a delayed permanent increase of the vascular permeability of the vessels, vessel endothelium, and that lead to edema. Fundamentally, the endothelial cell undergoes contraction and lead to permeability in the early transient phase of the increased vascular permeability which you see in the case of the acute inflammation is what you need to basically understand. Examiner is very choosy about all pretty micro level questions. Who will remember early permeability is because of what, late permeability, and what is the relation of becoming cardiologist or a nephrologist to that? Not much. But once more, when you post DM, you all talk about endothelial level only. Anyway, you don't talk about pedal edema is called nephrotic syndrome. You don't talk all those things after post DM when you are presenting in a scientific forum. You will say that yesterday night I got a dream that inflammatory cells are going to attack this part, and that is the reason our Indian patients have more of FSGS than MCD. And after waking up from the sleep, I have got to my rat laboratory and I picked up the rat and did a small research, and these are my histological findings you will present. Then immediately there will be a big clap in the scientific forum. Then next you will be flying to Hollywood, to Geneva to present your observations. Once more, same dream, same rat. With the rat you will be traveling across the world. So one of my classmates is he did MD general medicine with us, and after that he did DM nephrology, and finally he is going to Harvard now. After going to Harvard, he is going to give up the Littmann stethoscope. Actually he will bury the Littmann stethoscope before going. Why? Because after going to Harvard, he is doing a benchmark research. What is benchmark research? Early morning he will go like a, what is that movie? Like any other classical Tom Hanks movie. He will go to the laboratory, he will see, hello John, how are you? Then rabbit will come walking. Then let me see how is your renal transplant is working. Gross level in humans he finished everything. He had done lot of renal transplants, post-renal transplant rejections, renal transplant, lymphoproliferative disorders, steroid resistant and sensitive nephrotic syndromes, everything he finished nirvana in clinical medicine. Now he is going back to the benchmark research. Fundamentally all these questions of cytoskeleton level, contraction and all will come at that level. So maybe examiner expects that you finish your MD, DM, go back to the rats, rabbits and contribute to the science after finishing all the clinical work. It's also required. Up to 40 you can do the routine, same anesthesia, same clinical work. But after 40 you feel like having a change. So maybe 40 to 60 you work with rats, rabbits, everything. Once more after 60 you come back, by the time you yourself have diabetic nephropathy, slightly starting and presbyopic spectacles. Maybe then you will start once more seeing the patients. Up to 60 to 80, one fine day you will get angina in your own OPD and you will die. So that is our final extinction. Okay, on a little sad end. Now let's go to the next question. Macrophages, where are they basically found? Immediately after onset of inflammation, early or late phase? We need to know that neutrophils predominate in the early phase, whereas neutrophils will wean off by the time it is 3 days, and after that the macrophages will basically take up in the late phase. Coming to cytokines, they are the mediators of inflammation produced by macrophages. They are the soluble proteins. And is the attack of the cytokines, is it very specific or non-specifically they will go and attack? Cytokines basically attach with a high affinity receptors on their target cells. That's the reason generally their reactions are very specific in nature, is what you need to basically remember. What do you find in the secondary granules of the neutrophils? Basically neutrophils have primary, secondary granules. Myeloperoxidase, hydroxylases, they all appear in primary, whereas lactoferrin, alkaline phosphatase, lysozyme, they all are there in the secondary granules. So you should be sure what are the secondary and primary granules. Exam is all about specificity of knowing and not knowing. Major basic protein is formed by which cell? Fundamentally, where is it important, major basic protein? To kill the microbe. We are talking about oxygen dependent, oxygen independent mechanisms of the microbial killing, right? So the major basic protein is a cationic protein secreted by the eosinophils. It will kill the microorganism, and killing is by oxygen and oxygen independent. What are the oxygen dependent mechanisms? We have hydrogen peroxide H2O2 formation. Then there is a myeloperoxidase halide system where myeloperoxidase will cause HOCl, formation. They are the mechanism by which toxic radicals are generated, and that will kill the microbe after it got engulfed. So this is how you can see after the bacterium is being taken up, there are two ways by which it is being killed. One is oxygen dependent myeloperoxidase HOCl kind of system, and second is the specific granules, azurophilic granules. They throw the major basic protein and all those and directly kill it, oxygen independent mechanism. So two mechanisms, at least for today, let us be very sure. Then what are the oxygen independent mechanisms? The permeability of the cell membrane of the bacteria is increased and it will die. So that is how it is done by highly cationic proteins like phospholipase, major basic protein, etc., etc. Immediately after inflammation, there is a rise of neutrophils in the early phase, transient rise of neutrophils will be there. Now once more, All India 2008 question is delayed prolonged leakage after tissue injury is because of what? So earlier we were discussing a similar question, right? That delayed prolonged leakage from the vessels which occur in the when there is any inflammation is because of direct injurious effect caused by that organism or agent on the vascular endothelium. Second is cytokines which are released as a part of inflammation. They cause endothelial retraction and that lead to development of a delayed leakage. Cytokines also lead to vasodilatation, which lead to vascular permeability increase and seepage of fluid leading to edema, but that is not the cause for the delayed edema at the time of inflammation. Actually, inflammation and sepsis will fail your self-esteem as a physician, doctor. Somebody had a gram-negative sepsis, they come with a severe hypotension. What is the reason? A gram-negative sepsis release endotoxins, and those endotoxins will increase capillary permeability, and all the fluid is seeped out of capillaries, and that lead to severe hypotension. Normally, how do we treat hypotension? We give fluids, but if we do it here, what will happen? Pulmonary edema become precipitated, and all that fluid in turn will become capillary seeped out. So you will be a awful spectator of this drama of divinity, where your patient is succumbing, dying with a gram-negative sepsis. You know there is a shock. In spite of running fluids, patient is unable to recover because everything is seeping out because of increased capillary permeability. And there are some reasons for a early increase of permeability, some reasons for the late seepage of this intracapillary fluid out of the capillaries is what you need to basically understand. Then the last question of inflammation is bradykinin is basically the mediator of the pain, All India 2008. So the table of inflammatory mediators is one of the favorite area for the examiner.